It's a real pleasure to be here. It's an honor to be here. Given that we've got interpretation, I'm not going to talk through every slide. I'm going to go through the slides. The slides are going to be shared with you as a resource. So I'm going to focus on the key points, the key challenges, and some of the solution options we have for practice-based community health or health promotion. So bear that in mind, that my talk is going to be really focusing on health promotion practice. That is, health promotion is delivered as a program, as a project, as an intervention. This is the context that I'm going to be talking about health promotion in. Let's just talk about why working with community is really so important. And for me, one of the key issues that I found with my experience is that community-based organizations and community groups act as a bridge between state policy and often the last point of service and delivery, such as mental health services or local authorities or a primary healthcare center. And this is why it's so important to stay connected with and to build community-based options for us to work with in health promotion. We're also able to build social relationships. We're also to provide skills. And we know that this sort of an approach in general gives more control, helps to enable people to gain power or empower them in health promotion programs. Essentially, it's about getting the basics right first. And by that, I mean, let's do what we know works. Let's listen and engage. Let's share both community priorities and our priorities. And in order to do that, we need to perhaps develop our own skills in order to co-produce, to work together, to come up with ideas and solutions so that we can support local initiatives. And from a professional perspective, we need to be competent to do that. And this has been one of the problems traditionally that we lack as a profession, the competencies and the confidence, the experience to work with communities. And I think that's why we don't see it so much in practice. We need to be better listeners so we can have a meaningful dialogue and also a meaningful working relationship where we can share and work and co-produce. And to do that, we need to be culturally competent. We need to work in cross-cultural contexts and understand other cultural perspectives. We need to invest in these 4 key areas in health promotion from a professional practice point of view, around reaching the most vulnerable and underrepresented. We need to use interventions that we know, tailored interventions that we know from the literature, from the evidence, has the greatest impact, build our competencies. And we need to ensure that this network of community-based organizations and volunteers is sustainable. I just want to point out here that traditionally, community engagement has been based on a rural-based model. And as far as I know, there is no fully developed model or strategy for working with densely populated areas. The two contexts are very different. I saw this in West Africa during the Ebola outbreak, where had that virus spread into these sorts of densely populated slum areas, it would have been almost impossible to have worked in that context. They're inaccessible, they're not well organized, and there's often a lot of resistance. So without a fully developed, reliable strategy for this type of urban context, it presents a real risk in the future. The other issue I just want to, before I move on, is to dispel this myth that people don't want to be involved in health promotion or public health programs. There are lots of examples like these, where we can see where there's been a high level of participation, but it's true because from my own experience, the programs, I've been involved in programs that had very little participation. From my experience, it's about making sure that what we are doing is a priority for the stakeholders, for the community, or that they feel passionate about that subject. This is what motivates them, and this is what energizes people to get involved. People are passionate about climate change and get involved in that, but people are not necessarily passionate about obesity and changing their behavior. And we can see we've had lots of problems with this ourselves in health promotion, trying to get people involved in this issue. However, as we've also seen in other parts of the world, they do see it as a priority, and they are passionate about obesity in their own children. So this is the key difference, why people do or do not, I see it, get involved. Let's just look at quickly a couple of quick solutions for mobilizing and energizing communities that we know work in health promotion. Community champions or health champions has been used in a number of countries. In the United Kingdom, thousands have been recruited to promote health. These are local people that use their social networks and their experience to improve connections between resources and services and the people that need them the most. The key thing is they're versatile, and such as these ladies in the picture, organizing an exercise class, but they can plan and help communities to organize and share information about a range of issues. The key point here is these types of what I call credible connectors within community, health champions, can fast track trust building and energize communities. And this issue about trust and the need to build trust and how do we build trust and do we need to build trust is often an issue when we're working with community. It's often also a red herring because we don't necessarily need to do it. The other example is based on peer education, which we know works, and working in small groups. And I'm using the example from migrant mothers, madres comunitarias, or community mothers that has been used in a number of countries around the world, where peers, migrant mothers, help other migrant mothers, meeting small groups to discuss issues about access to services, access to cheap and culturally appropriate food, or work opportunities. The success of this type of an approach of using peer education and small groups together or separately is that essentially it's giving the stakeholders more control over decision making. Essentially, it's enabling them to empower themselves. And this is the success of these types of programs. So that is looking at it from individual interventions. What would it look like at a national level? Well, if you want to look at something with more detail, you could look at Public Health England's community-centered framework, which is a very comprehensive framework and focuses on these 4 key areas that I've just been talking about: strengthening communities, maintaining a network of volunteers and peers, collaborations between services and businesses and communities, and better access to community resources such as community champions, the people, and also community spaces where people can meet. But it does raise the key question on who is responsible. If this is so important, which it is, who is responsible for strengthening and maintaining a network of community groups and volunteers in society? Because traditionally, governments do not see it as their responsibility to support the non-government sector. In fact, in some countries that I've worked in, the non-government sector is seen as a threat, and governments have purposefully tried to dismantle the third sector, the non-government sector. So this is a key issue that we need to think about. And that also brings me to my first of 2 challenges in this presentation. We have to be prepared to listen to what the communities or the stakeholders need. We might not like what we hear because it might not fit with our top-down agenda, but we have to be committed to moving forward to co-produce, co-design health promotion programs in the future in order to have local success. And I think we also need to ask some questions before we start listening to communities or listening to stakeholders. So these are some of the questions I often ask myself at a program implementation level. What is the purpose of the engagement? Is it just to get people to participate, to pay lip service to participation? Are we trying to coerce or manipulate the community, the stakeholders, to be involved? Who are they, and who are their representatives? How are they selected? And we use a lot of technical terms in health promotion, community empowerment, community participation, capacity building, whatever. But the language that we use, if we want to really co-design, the language that is used at the community level is very different. So we need a common language. We need to make sure that we all understand what we're talking about when we're working with community. Now, engagement, listening and engagement is a whole workshop that I do in itself. So I'm just going to touch on it here and say that when we are listening to stakeholders and communities, it's good to use sort of mixed methods, various channel approach. We can use face-to-face community forums or village and neighborhood meetings, for example. Now we have lots of digital solutions, online polls and surveys, social media groups. And also we can get secondary sources from health services, local authorities, businesses where people have, raised issues or made complaints. And also in terms of how we engage, the strategies, the tools that are available are all online. For example, community engagement and accountability by the International Red Cross, Red Crescent is a very comprehensive strategy set of tools, as is SARA and FAST in the water and sanitation sector, which I've used myself many times. Community-led Ebola action is something I found very useful and could be easily adapted to many different approaches. And even UNICEF has its own minimum quality standards and indicators for community engagement. So really there's no reason why we should not be engaging with communities and stakeholders. It makes me ask myself why we don't, because it's rare. It's rare in my career over the last 40 years in health promotion that I've seen, communities engaged with as a key part of the project design early on and as an ongoing part of it. So why don't we do this more often? I'll just give you a quick example of something I used, a tool, I'm sure you're aware of this, Photo Voice in Spain. People use their mobile phones to take a picture and use a narrative. We used it in a poor inner city multicultural community in a city in Spain where we engaged with 39 families. And through WhatsApp, they sent 85 photos about their experiences during COVID lockdown and what their needs were. And these photos and narratives reflected people's sense of loneliness and need for support, but also how they helped one another, such as the photo in the top corner showing how people were making face masks at the beginning of the lockdown because they were not available. The key thing with Photo Voice is it's often used as a tool to collect data, but that's not enough. We need to have follow-up action. In this case, we had an exhibition of these photos to share them with municipal leaders, and that information also fed into intersectoral meetings because there are clear intersectoral implications for developing health promotion programs to reach the vulnerable, to deliver services, for example. Sorry. So that brings me to my second challenge. In this top-down, bottom-up world that we're living in health promotion and this tension that creates, how can we better co-produce programs together? Because we need to do that for more success. Well, I recently did a literature review on co-production and community engagement, and this term co-production, co-creation, co-design is not necessarily new, and there's no one definitive approach. The simplest way of looking at it is it's a way of working together to share ideas between the different stakeholders for ideas and decision-making that will lead to improved health programs or service delivery and healthy environments. It covers obviously culture and diversity and organizational structures and practices, but it really should involve a clear step-by-step approach on how we're going to engage and work in order to co-produce health promotion programs. So let me just talk about two quick examples of how this might look in practice, or how it does look in practice. Patient involvement action groups or similar groups exist in many clinical settings, which enables patients. Hello? Okay. So it allows patients to get involved to engage with the services and with the care that's being delivered. And it also allows them to have a voice, to have a representation. These issues are shared, they're prioritized, and in a number of occasions, these sorts of approaches, these sorts of co-creation approaches have led to a reduction in the number of complaints because patients feel that their needs around privacy and comfort and information are being addressed, being heard. And from a community perspective, well, the Safer Park scheme is a scheme that's being used throughout the world as well. Countries like Pakistan, India, I came across it when I was working in New Zealand. Often parks, open spaces, particularly in inner city areas, have problems with crime and drug use and litter and graffiti. And this makes them dirty and unsafe for local residents to use, who often are low socioeconomic and they need to get access to them. So in this case, the city council employed people to clean up the parks and recruited community volunteers or community connectors to patrol the parks. But then there was a period of co-creation, of co-production, where local residents work with the Department of Conservation and City Council to develop and adopt a park scheme. And local residents were much more involved to raise money and clean the park and look after the park. And the City Council invested more resources such as exercise equipment. And this led to the parks being used, being available for families, for picnics and exercise, and therefore led to a more active and healthier community. So co-production is not new, it's simply about working together, and we can see many examples already in health promotion about how this is done. I think the way to improve this is for it to be more systematic and for it to begin at an early stage and to work through, all the way through. Now, I'm aware that many of you won't have time to, may have not understood my presentation or may not have time to read all the slides. So as a takeaway, there are just 5 key points that I think, the slides will be available, but 5 key points that I think you should that you should really focus on. We need to listen, we need competencies, we need to co-produce, we need to work with community champions, community health workers, credible connectors to build trust and energize communities. And we need a network of community groups and volunteers that must be sustainable in order to work better at the community level in health promotion. So thank you, merci, and gracias a todo. And I'll now pass it over to Eric.
So I'm Eric Breton, from the French School of Public Health. It's a real pleasure having you all there. We had many people enrolled from all over the world, and I understand that many are from French-speaking countries. So I thank you very much, Glenn, for what you presented. And one of the reasons we set up the Global Community Health Annual Workshop was really because there's so little resources invested in community health. I mean, in many countries, community health is basically the poor child of public health. I think that many of you will agree, and you can comment on that on the chat if you will. And definitely, when I look at, I mean, I've learned a lot from you, Glenn, from your papers, from different contributions in scientific papers. And one of the most striking thing that I got from you was basically I train many professionals, I mean, working in regional health agencies, for instance. So people are basically funding, developing programs. And one of the key issues when we tell them, you need to engage the population, you need to have them more participants of to participate in the action. One of the things is clearly they say, well, it's difficult for us because we we have to develop programs. We have to set what are the goals of the program, and then we have to fund the program. So it's very difficult to not be top down in the way that we generate things. But Glenn Laverack, in one of his papers, he actually said, well, you know, you cannot, of course, you can be, you'll be top down in the way that you generate programs, but there are ways to actually create kind of spaces where people can be engaged. And this is much of a relief for many professionals. I mean, people who actually have to manage programs that needs to be delivered at the local level, to know that actually, even though they are in a situation, in a position that makes it difficult for them to be button up, to engage people, they can create those spaces to actually generate engagement. So this is one point I would like you to comment on. The other thing, when you say that people want to be involved, this is so true. And again, if people that are actually listening to us have examples of that, I mean, feel free to put them in the chat. People want to be engaged. They don't, but the thing is, most of the time, what we ask them is to be like some kind of obedient participant in our programs. We want them to say, well, get on board, but I mean, you have to do as the way we tell you to do. And the thing is, one way to engage people is definitely in the example you provided was actually a case. I mean, a good example of that is that you need to give people roles. They need to have a role in the program. If you don't have a role to play in the program, be it very simple things, such as we need tables, so to actually organize this community activities. So where do we find the tables? Can someone find the tables? We need people who actually have good networks of I mean, within the community, so they can actually spread the news about what's going on. I mean, so you have a lot of expertise, knowledge, skills done there. But if you don't actually mobilize the skills by distributing roles, I mean, not saying this is what you need to do, that will fail. And one of the key things, and we've seen over the past few years, is this idea that in public health, if you work in an organization that is developing programs and things like that, one of the key roles that you should pay attention to is that you're not there to tell people what to do. You're there to inspire people about what is the destination, towards what destination they should maybe consider going to. So for instance, if your thing is about physical activity and you see that, well, people don't exercise, their level of physical activity is poor, you don't tell them how to integrate physical activity in their life. You can say though, you know, the best way to actually increase the level of activity, the physical activity, is to actually to walk and cycle. I mean, to reach destination by walking and cycling. How to do that in that specific community, you don't know, because you're no expert in the community. And that's where basically you can engage people to find solutions on how do we make our streets safer. How is it possible for a woman, for instance, to go out at night and go, I don't know, go have some leisure activities and get back home safely? So over to you, Glenn. So what
Thank you very much, Eric, and thank you for reminding me about this top-down, bottom-up tension. We can find solutions for this, and if you look. I've posted a paper as part of my presentation, only one paper, a short paper, which talks about something called parallel tracking. And you can look at that paper and it will explain how we can address both top-down and bottom-up needs together as part of the program design. The other thing I want to share with you, because I know that many, and thank you, Eric, for reminding us that many people are from the Francophone context, the French Francophone context, yeah, of course. This book talks about everything I've spoken about so far, obviously in French, specifically for the Francophone African market. It's free. The book is free. So that's why I'm showing it to you. So many of you might want to get a copy of this book. You can download it at lulu.com, LULU.com. Go onto there. You can either buy a hard copy of the book or you can download it for free. We get no royalties from this, but David Hoto, who's my co-author, who is based in Benin, any monies we get from this book, we put into buying books for students in Africa, free books for students, the hard copies. So please, if you want to use that as a resource, everything I've talked about, most of everything I've talked about today is in that book in French, but with case studies from Africa. Okay, thank you very much.